Good afternoon, everyone. My name is Troy Jorgensen. I'm the program coordinator here at Project Echo Nevada. And today we have Dr. Nevin Wilson from the UNLV School of Medicine presenting about the new newborn screening program for severe combined immune deficiency. Just a couple of housekeeping things. I have everybody on mute. So if you're on Zoom on your computer, please feel free to unmute yourself with the icon in the lower left corner if you have any questions, or feel free to use the chat function as well. And if you're joining by phone, use *6 to unmute yourself. So without further ado, I'll turn it over to Dr. Wilson.
Okay, thank you. I'd like to thank everybody who is going to be here this afternoon. This is going to be something that's going to be extremely important, I think, to all of us here in Nevada. This is a game changer when it comes to dealing with immune deficiency, and it's going to be challenging in a lot of ways. Part of the problem here is that, for example, I've been back here in Nevada for almost 10 years, and I've had 7 children that were diagnosed with severe combined immune deficiency since I've been here, and all of them are deceased. And the reason is that we are not getting to these children soon enough, and they're getting infected, and the infections are things that these infants cannot cope with, and there are things that we cannot treat in a number of cases. So literally last month, I had a 9-year-old from Pahrump who had actually X-linked severe combined immune deficiency pass away from severe varicella encephalitis. He was not, in fact, diagnosed until he was 7 years of age. And it's a good example of, of one of the myths about severe combined immune deficiency is that you can't survive until you're a little older. He most certainly did, although I think he was out in Pahrump and probably was a little bit isolated. May I have my first slide, please? How do I move to the next slide? Okay, so the first question is, what is severe combined immune deficiency? Severe combined immune deficiencies are a number of genetic disorders in which both the B lymphocytes and the T lymphocytes of the immune system are impaired. So it is a severe form of inherited immune deficiency. It's also in the general world known as the bubble boy disease. And it results in an immune system that is highly compromised, and for all intents and purposes, usually is just absent. So infants with this disorder are at very high risk for life-threatening infections early in life. And the problem is that they look totally normal, and they carry the mother's IgG antibodies, so that they'll usually leave the newborn nursery, and it won't be until after they've been exposed to a number of different viruses or infections that anyone may even question that there might be a problem. And unfortunately, for example, cytomegalovirus, that alone is pretty much fatal in one of these infants. So as I already alluded to, surviving with this disorder under normal circumstances is very difficult. They don't get diagnosed. It very often is only until one child has already died of severe infection and there's another child that comes along in the family that anybody starts asking any questions about whether or not there might be an immune deficiency. Okay, so let me back up here. This actually is the bubble boy. He had X-linked severe combined immune deficiency. And unfortunately, it turns out that this idea doesn't work. No matter what happens, if you're in a bubble, eventually you die of overwhelming infection of some kind, or for some other reason like lymphoma or leukemia gets to you. Without the immune system intact, this disorder is basically a non-survivable condition. So if you look at different types of immune deficiencies, B-cell deficiencies end up with absent or reduced follicles in the lymphoid organs, and most importantly, reduced immunoglobulin levels. And so people who have B-cell deficiencies will tend to have problems with pyogenic bacterial infections, enteric bacterial infections, and viral infections. So if you've got a humoral immune deficiency, a B-cell deficiency, you will tend to get infected with things like pneumococcus, Haemophilus influenza, Moraxella. You will tend to have pneumonias. You will tend to have sinus infections. You'll tend to have gastroenteritis, that sort of thing. T-cell deficiencies, it results in reduced T-cell zones in lymphoid organs, reduced delayed hypersensitivity reactions to common antigens, and defective T-cell proliferative responses to mitogens. And basically, when you have a T-cell defect, it is going to be viruses and other intracellular microbial infections, particularly things like pneumocystis, fungi, non-tuberculous mycobacteria, and particularly viral-associated malignancies tend to be the consequence of that. And then finally, when the innate immune system is involved, it's a variable depending on which component is defective, but you'll tend to get pyogenic bacterial and viral infections, joint infections, meningitis, things of that nature. By the way, if anybody has any questions at all, please chime in. This doesn't seem to. All right, oops. This is just a table of the various types of severe combined immune deficiency, their inheritance pattern, the gene involved. The reason that I put it up there is not that it's going to be terribly important to this discussion, but the main thing is if you look at the lymphocyte subsets, very typically we can ascertain what type of genetic defect is going on simply by looking at the pattern of the CD3, CD4, CD8, CD19, and CD56 antibody that we're measuring. Somebody have a question? No, I guess not. So if you are T negative, B positive, NK positive, the NK stands for natural killer cell, then it's going to tend to be in this group here, IL-7 receptor alpha chain deficiency, CD3 complex deficiency, that sort of thing. The more common one is T negative, B negative, NK positive, and there's a whole bunch of it, recombinase activating gene deficiency, Artemis, and then T negative, B positive, NK negative, common gamma chain deficiency. That was the one that my patient had most recently, who's expired. And then finally, things like T negative, B negative, NK negative is going to be like adenosine deaminase deficiency. So the importance of this slide is just going back to the importance of getting T-cell subsets, flow cytometry on these infants early on. Wait, it doesn't want to, these slides don't. There must be a delay here. Okay, again, this is just a slide showing where these various disorders occur. This is the human stem cell in the bone marrow. And these are pro-B cells. Pro-B cells turn into pre-B cells, and then finally mature B cells. So if you have a defect in one of these, the recombinant genes, or with BTK, Bruton's tyrosine kinase, or Bruton's agammaglobulinemia is the most common gene for agammaglobulinemia in this population. This is where these genes are. On the other hand, if you've got a defect in, say, the gamma chain or adenosine deaminase or one of the others, this is the T cell pathway. and you end up with defects in primarily the lymphocytes. So that, again, as we've mapped out all of these different genes, we've discovered various patterns of immune deficiency based on the immunoglobulins, the T cell numbers, and lymphocyte function. This shows just the breakdown, as we now know from the, mostly from the newborn screening that's being done in other states. As you can see, even at this point, unknown as to what the disorder is still about a quarter of all of these infants. So there's a lot of infants we're not able to get genetic information about the specific disorder, but they still have severe combined immune deficiency. Again, the most common one of this IL-2 receptor gene defect at 19%. That's X-linked. That's what my patient had. The unusual thing was my recent patient was just simply that he was that old at the time that he survived until he expired. There's also something that you need to know called a leaky skin. Leaky skin turns out that these have more T lymphocytes than other infants with severe combined immune deficiency, but they lack naive T cells. The T cells that they have are functionally impaired, and so they just don't work. And so the T cell subsets will show some T cells there, but it's apparent that function is a big problem. And there's a specific disorder that has adenopathy, red skin with severe eczema, intestinal T cell infiltration, hepatosplenomegaly, eosinophilia, increased IgE levels, and this is known as Omen syndrome. As a teaching point, I always remind everybody that eczema plus failure to thrive in an infant equals immune workup. If you've got an infant with bad eczema, say like a 3 or 4 month old, and he's got that eczema all over him, and he's not growing that great, don't wait until the first infections start. Start the immune studies then. So anyway, the leaky skin is a variant that has some lymphocytes, but their function is not very good. So what is the treatment for these disorders? Well, over my career, I've probably had about 20, 25 of these infants that I have taken care of. Again, they're all very rare disorders. I would say about 2/3 of them are survived, mostly because of bone marrow transplant. And unfortunately, since I've been in Nevada, my batting average has dropped considerably. The most important thing to treatment is avoid infection and get to the patient early enough so that you can do a transplant. And the best of all worlds is if you can find a sibling or a brother or sister who's a good match. The success rate for these transplants is actually excellent. And even if you have a haploidentical bone marrow transplant with a mother, it's still actually very good. The most recent data, as you can see here in 2014, if the infant is less than 3.5 months of age, the 5-year survival after bone marrow transplant is 94%, but it drops down significantly so that older than 3.5 months is down to like 50%. So again, this is why this newborn screening program is so important. This is why we need to get to these kids, identify them, and start working them up and treating them before they get severely infected. The other thing that has been done is gene therapy, and that has been useful for adenosine deaminase deficiency and X-linked IL-2 receptor gene. So let's talk a little bit about newborn screening, because that's the big change here. What happens is ordinarily pro-T cells and pre-T cells are born in the bone marrow. And then they migrate to the thymus. The thymus is a gland that sits in our mediastinum. And what I like in the thymus is like postgraduate education for T lymphocytes, or a residency program for T lymphocytes. The T lymphocytes go to the thymus, and in the thymus, the ones that are overactive and respond by activation in the absence of an antigen get eliminated by the thymus. And those that won't respond at all are eliminated by the thymus. And so you end up with a graduate T lymphocyte that can respond to antigen, but only in the presence of the HLA antigens. So in other words, the cells that are going to go nuts and attack the body are eliminated, and the ones that are too weak to respond to anything are eliminated, and you end up with a collection of solid T lymphocytes to help protect against infection. All infants with SCID fail to develop a diverse repertoire of mature T cells. And so as a consequence, they have low numbers of Tregs. Excuse me, I've got a cold right now, so I apologize for that. Tregs stands for T cell receptor excision circles. And they're what is left over when a T lymphocyte reorganizes its T cell receptor genes. So here's an example of the T cell receptor genes. You end up with a recombination, and you end up with one J section being applied, and then you get combination with the VDJ, and eventually what you end up is with an mRNA that has one specific gene for making this T cell receptor beta gene. So this is how the immune system reorganizes all of its genes so that the cell can respond to one particular bacteria or virus. It's a Nobel Prize was won for figuring this all out, because nobody knew, like, how do we make antibody? How do we have T cells that are very specific for, say, tuberculosis and not something else? Well, it turns out it was the rearrangement of this gene to make this mRNA, this VDJ rearrangement was the reason for it. Why am I telling you all of this? Well, this is what happens, is that you end up snipping out the parts of the gene that aren't supposed to be there. So as they recombine the sections of the gene, you end up with these little sections of Tregs, these little circular things that end up in the blood that are, left over from this rearrangement process. So this becomes a beautiful way for us to screen early to tell us whether or not the thymus is working and whether or not the infant has got an immune system. And so we can screen for these Tregs at a very early age, is in the newborns, right after birth, and determine which infants we need to pay more close attention to. So what's happened is a lot of states have instituted newborn screening for SCID. And basically, you may have been taught in the past that the incidence of a newborn having severe combined immune deficiency was 1 in a million live births. Well, what we have found out is that was wrong, and that in fact it was much more common. It's probably closer to like 1 in 50,000 live births, but that most of these infants were in fact not being detected and not surviving. So Wisconsin was the first state to implement newborn screening for SCID in 2008. And by 2014, 11 newborn screening programs have screened over 3 million newborns with this Treg test. And basically, the data from California shows that non-SCID T cell defects are 1 in 20,000, Wisconsin was 1 in 58,000. That is dramatically less than the previous thinking that these were exceedingly rare diseases. This shows the status of all the newborn screening programs in the United States. As you can see, we are developing our pilot right here. So only Louisiana and Indiana have not implemented screening. So I am pleased to say that Nevada will not be the last state to implement newborn screening. And this shows the difference in the way, this is the incidence of SCID being diagnosed based on family history. It's dramatically dropped in 2010. About half the time it was the family history that identified the patients. This is the incidence of diagnosis based on infection. And it's gone from like 55% down to about 10%. And as you can see, the number of infants diagnosed via newborn screening has dramatically increased. So if you look at newborn screening in California, this is initial results. They screened 217,000 patients. They had 4 patients with SCID, 1 with DiGeorge, 1 with non-SCID T-cell lymphopenia. They had negative flow, and then they had a number of them, that 229 that were a little bit more inconclusive. And that's something we'll be talking about a little bit more here in a minute. So in the end, this is, you had 217,000 initial specimens. This is from August to December. They had 157 second heel sticks. 26 were referred for flow cytometry. They ended up with 5 with SCID, 2 with DiGeorge, 2 non-SCID T-cell lymphopenia, 10 that ended up negative, 4 that expired, and 3 that were pending. And from the second heel stick, you ended up with ultimately, during that period of time, 10 that were positive and 3 that were inconclusive. And that was just from a short period of time. It's really important to appreciate that SCID is not the only disorder that is picked up by this test. So there are other syndromes, the most important of which, as far as frequency, is going to be DiGeorge. As you probably are aware, DiGeorge are typically chromosome 22q11 deletion syndrome, is a disorder that very often has congenital heart disease, hypoparathyroidism, various facial and chest abnormalities, and about 10% of the time, no thymus. And so most of these kids get picked up because of the heart problem. But what we're discovering is that a certain number of kids with DiGeorge didn't have the heart problem, and they're now getting out into the general population without being diagnosed. So DiGeorge gets picked up, and then there's also these secondary T lymphopenias. So that there are some kids, including 3 that had neonatal leukemia, but there's also some that have this idiopathic T-cell lymphopenia that we actually don't know a whole lot about. The critical thing here is that not every infant who comes back with a low Treg is going to have SCID. The other thing that I want to point out here is that it picks up preemies. So if you are a premature infant, a very premature infant, you might not have developed enough of a thymus and enough thymus function to have enough T lymphocytes to be picked up. So one of the things that we're going to be conscious of is that there's going to be a certain number of phone calls that we're going to get from neonatal units across the state about infants that this test has come back negative, and what are we going to do about it? And there's kind of like 2 schools of thought. One is you just wait until their gestational age is equivalent to full term and then repeat it. Then the problem with that is it turns out that there are preemies with SCID too, And so probably the thing to do is to repeat it 1 month after the first test. So, as I said, this test identifies infants with low Treg numbers who do not have SCID, but nonetheless have got lymphopenia. There is this thing now that we are calling idiopathic T-cell lymphopenia, and some of them, it's benign. The T lymphopenia is clearly present. We have to follow them closely, and basically, eventually they come up on their own. And this is going to be one of the dilemmas, particularly for myself and other immunologists in this state, is that there's going to be a few infants that on paper are going to look pretty immunosuppressed, but when we repeat the studies, things are going to look better and better, and basically they have what's called transient lymphopenia of infancy. So that's something we're going to have to be very much aware of. The other one I would like to point out is there's a certain number of infants who undergo cardiothoracic surgery because of interruption of their thoracic duct, and having a chest tube in will also end up with lymphopenia and might end up with an abnormal test. So again, part of the problem with all of this stuff, reference ranges have not been established for neonates less than 37 weeks. So all we can do is follow those infants, be aware of them very carefully, you know, and not let them escape the neonatal unit. As I've mentioned, there is this poorly defined T-cell lymphopenia, some of which are clearly abnormal and immune deficient, some of which are transient. And the good news is we're developing much more sophisticated PCR, or polymerase chain reaction methods, to screen for additional immune deficiency diseases. So now, what are we going to do with a positive result? Well, that's what we got to be worried about. That's why I'm doing this talk. That's why we're all going to have to stay in communication with each other. This is a nice flow chart that was developed by the California screening system. So let's say you have a non-normal Treg screening or a family history or clinical features. A positive is lower absent Tregs with a normal control. Incomplete is indeterminate, is low Tregs and low control on at least 2 samples. So at this point, a CBC will provide useful information, but what we really want is CD3, CD4, CD8, and then the percent of CD45RA naive T cells, and then finally CD19, which is the B cell marker, and CD56. So if the number of T cells is greater than 1,500 and more than 200 naive CD4 cells present, we just watch. If these are low,
yeah, well, you bring it over there.
Yeah. Can you hear me okay? Okay. If these are low, less than 200, this is going to typically be a SCID or a leaky SCID. And what we have to do is get them hospitalized, isolated, keep them away from people who are sick, and treat them with IVIG and prophylactic antibiotics. And we'll talk about that more in a few minutes. Then we're going to have to do the more definitive tests for immune deficiency, mitogen responses, and also then looking at genetic studies. If, for example, there are low T cells, but some naive T cells are present, it may very well be that this is secondary T lymphopenia or this idiopathic T cell lymphopenia, and we're just going to have to follow them all very, very closely. This is a table that shows the approach of management of an infant with a lymphocyte subset profile consistent with SCID. We isolate the infant in a treatment room. We keep all sick contacts away. Again, it's important to realize a rhinovirus infection could be fatal in some of these infants. We diagnose and treat any clinical abnormalities. We deal with respiratory distress or any evidence of infectious or autoimmune conditions. I've had a number of infants over the years that presented with pneumocystis as their first sign of infection. We get social work involved. This is something that's really important here. No live viruses, okay? No live virus vaccines, rather. Any kind of vaccine that has anything that is still, just an attenuated but live organism is going to be extremely dangerous in one of these infants. We need to stop nursing while we evaluate whether she might have CMV. If she's CMV negative, we can resume nursing. If she's CMV positive, then we have to stop at that point. We also have to look at CMV PCR weekly. We need to get intravenous access so we can give gamma globulin. We have to get, it's very important for nutritional support. As I've mentioned, failure to thrive is a very important part of these infants. Very often they're anemic. Sometimes they'll make an antibody against their own red blood cells, so they'll have autoimmune hemolytic anemia, and that will be like the only antibody that they're capable of making. We're going to give them IVIG to maintain an IgG level above 800. We're going to treat them with palivizumab for their RSV or to prevent RSV. And then we're going to start them on fluconazole, acyclovir, and Bactrim after 30 days of age. And then we start looking for a donor. We're going to HLA type the family, and we're going to start looking for who can do the bone marrow transplant with this infant. This is a good list of the dosing and the notes for the various drugs that we're going to need. The most important one is going to be the IVIG. Again, with SCID, both their B cells and their T cells are impaired. The only antibody that they have to protect themselves is mom's antibody. And so getting a good, reasonable dose of IVIG in is something that's going to be essential. Bactrim prophylaxis for pneumocystis is essential that we get going as soon as they're 30 days old. And then acyclovir, fluconazole. And then if it turns out they've got adenosine deaminase deficiency, then there's PEG-ADA that we can also start on these infants. This kind of reviews all of the other things that we need to do. So we need to take a very directed history, looking at infections, family history. We need to look at a pedigree. We need to look at the issue of consanguinity. Physical exam is going to be particularly important for looking for signs of infection, skeletal abnormalities that are seen with some of these disorders, and congenital abnormalities. Rashes, particularly eczematoid rashes, are very much associated with some forms of severe combined immune deficiency. We're going to get those T cell subsets, including CD45 Rho and RO, using flow cytometry. That's essential. It's always a good idea to look at liver function tests and albumin and total bilirubin. And then we've got to screen for HIV, herpes virus, Epstein-Barr virus, hepatitis B, parvovirus, adenovirus. These all may need to be done in some of these patients. Fortunately, the younger the patient, the less we're going to have to worry about that. We always want to get an IgG, IgM, IgA, and an IgE level. That's part of the important early screening. PHA stands for phytohemagglutinin. Phytohemagglutinin is a mitogen. Normal lymphocytes will respond to PHA by proliferating. Abnormal T lymphocytes will just sit there and do nothing. So a PHA mitogen response for this particular population is an essential test to tell us whether or not the T lymphocytes are functioning. So again, once the Treg test has demonstrated to us that we have a problem, we get the T cell subsets and the PHA response along with the immunoglobulins as the initial studies to determine whether or not they really have severe combined immune deficiency. And then other tests, as indicated, depends on whether we suspect it's a adenosine deaminase deficiency. The beautiful thing, we're starting to get these genetic array studies that my friends at the NIH have a genetic array for immune deficiency that can do over 100 immune deficiencies, genetic tests all at the same time. They have been very useful to me in a number of cases. So usually one of the first people that I end up talking to are my colleagues at the NIH. And then again, unless you're worried about certain kinds of genetic immune deficiencies, particularly the chromosomal breakage syndromes, getting a chest x-ray to look for a thymus and to look at the lung parenchyma is a good idea, along with the bony structures of the chest. So again, this is kind of reviewing the same thing over again. The initial evaluation, T cell subsets, PHA mitogen response, immunoglobulins, perhaps studies looking for viruses, perhaps looking for 22q11, eliminating live viruses, starting them up on appropriate antibiotic prophylaxis, getting them started on IVIG, and then it just depends. If they've got congenital anomalies, we go immediately to gene sequencing, and then we try to move forward with an established diagnosis and treatment. If they're T-cell lymphopenia with no other syndromic features, and everything looks pretty good for the T cells, we'll just watch them repeat all these studies at 7 months of age. And again, this gives an idea of how much blood should be needed for most of these tests. I have done most of these tests at one point or another in the laboratory. If your laboratory is telling you you need 5 to 7 mLs of blood for a lot of this stuff, that's clearly a real problem. And we're working hard down here to try and get all the laboratories to really go with a much smaller amount than what they've requested in the past. This shows the different tubes involved. Again, some of these things like the immunoglobulins, we should be able to get at pretty much any hospital. Other tests are going to be a little bit more difficult to arrange immediately. So what can we conclude about this? Advances in newborn screening for SCID over the last 9 years have profoundly changed and improved the outcomes of children born with SCID in the United States. There is a lot more early diagnosis in these states. There's a lot more infants that are surviving this disorder, and a lot more infants are making it to bone marrow transplant without infection. Infection is the problem that is fatal to most of these infants. But without any question, all of the studies show that this has been uniformly successful in all the states that have implemented it. And I am really excited to be a part of this here in the state of Nevada. This is the various publications for references that if you want to learn more about this, that I provided, particularly let me back up here. The most recent one here. This one here is particularly useful. And this one here, statewide newborn screening for severe T-cell lymphopenia. Finally, this is my address, this is my phone number, this is my fax number, this is my email, and this is my cell phone number. If you have any questions at all, call me. If I don't know the answer, I will immediately find somebody who does. But I think the only way that we can handle this, particularly in the next year or two, is for all of us to stay into close communication. These kids are going to show up everywhere and anywhere, and we have to be prepared for that. And like I said, there's going to be some surprises. There's going to be kids who look like they have an immune deficiency but don't. But there's going to be other kids that nobody suspected anything who really have severe combined immune deficiency. So at that point, I will open it up to discussion and any questions that anybody might have.
Thank you so much, Dr. Wilson. That was fantastic. Yes, if anyone has any questions, please feel free to unmute yourself with the icon in the lower left corner of your screen. Or if you're joined by phone, it is *6.
Okay, I guess nobody has any questions at this point.
Any questions at all?
Okay, well, if you do, you have about every way there is to get a hold of me now. And I welcome the phone calls, the emails. We'll have to work together on this.
Yeah, Dr. Van Gelder, please.
Hi. So this looks like it's coming down very close to being done here in Nevada.
Yes.
Is that going to be standard across the board for all hospitals? Is it going to be slowly integrated? Do we know?
It's going to be, I think it'll be done just the exact same time and way that the rest of the newborn screening is done, just from the heel stick.
Okay.
That's the beautiful thing about it, is that they can find the T-Rex on that little blood spot.
Right. And then it will be just standard of care for anyone who is ordering a newborn screen, that all hospitals will be now adopting the new
Yes.
one? Okay.
Yes.
Great.
Can you hear me?
Yes, I can hear you.
Okay, great. I'm Nancy Baker. I'm a family physician out here in Ely, Nevada. And my question is, number one, have you ever seen SCID present in older children? Is there any type of, I guess I'm asking, can you turn on a gene? Have you ever seen that? And number two, can you describe a typical case that you have seen with SCID? Thank you.
Well, first of all, as I said at the beginning of this, I just recently had a 9-year-old pass away from severe varicella encephalitis, who turned out to have X-linked SCID, IL-2 receptor gene defect. And we're still trying to understand how he ever survived to age 9. He was not diagnosed as immune deficient until I met him at age 7, when he was hospitalized for severe pneumococcal pneumonia. And the problem was I couldn't get any kind of donor for a bone marrow transplant. And we did everything we possibly could to treat him, but the varicella, is what did him in. And it turned out, when we looked back at it, he had been immunized with the varicella vaccine. So it is possible, although the typical severe combined immune deficiency patient usually presents between 1 month and 6 months with failure to thrive and recurrent infections that don't respond to antibiotics, or are overwhelming, or are severe viral infections, or with non-pathogens. So, a very typical one that I had was an infant that had been seen multiple times. This is back when I was in West Virginia. This infant had been seen in a clinic multiple times for pneumonia and ear infections, and just had the dwindles. And at about 4 months of age, the physician couldn't figure out what was wrong and thought maybe it was a heart problem. and sent the infant to the cardiology clinic. And the cardiologist took one look at the infant and called me and said, "Get down here now," and because I don't think this is a heart problem. And on chest x-ray, he had a complete whiteout, and he had pneumocystis. And fortunately, he did not have CMV or other viruses, and we were able to stabilize him, get him treated, and he eventually had a bone marrow transplant from his mother. And I would imagine by now he's probably like 13, 14 years old. So that would be a very typical example of it. What unfortunately I've seen, particularly since I've been here in Las Vegas, is that I get called about an infant that's in the pediatric critical care unit and has horrible pneumonia and looks terrible, and they can't ventilate the infant. And they just got the report back saying that the infant's got 100 million colonies of CMV on some test. And then I do the studies, and the infant's got CMV and severe combined immune deficiency, and there's no way to save the infant. Newborn screening, I pray, will prevent all of this. Any other questions?
One other.
Sure.
Hi. So what are the outcomes generally with the bone marrow transplant?
Well, it turns out if you get to them in the first 3.5 months of life, 92% survival rate. If you get to them after 3.5 months of life, drops down to 50%.
And what's their life like after that? If it's successful, do they have like a normal immune system life down there?
Absolutely. Yes. Okay. The ones that get through the whole thing, I've met adults. In fact, there was a physician, a pediatrician in West Virginia, whose daughter had severe combined immune deficiency and got transplanted. And then he brought her in and introduced me to her. And she was like 23 years old and totally normal and hadn't had a problem in decades. And he literally brought her in just so that he could say, this is what somebody looks like who has gotten through the transplant and survived. Now, what these people will be like in their 50s or 60s, I don't think anyone will know that.
Mm-hmm. Thank you.
Hello?
Hello.
My name is Natalie. I'm a nursing manager up in northern Nevada, and I am wondering what I can expect so I can help educate some of my staff. Certainly, we do newborn screening, but I'm wanting to know on this program what kind of rollout is going to happen and what kind of changes can I expect to tell my nurses?
Well, I think the thing that will happen is that, you know, as part of the current newborn screening, they will do this screening for T-Rex. If the screening for T-Rex is abnormal, then two things will happen. They'll call the patient's physician and let them know about it, and they'll call me, and I'll probably be on the phone with the patient, the infant's physician, shortly thereafter to try and get more information. A lot of these infants are going to pop up in the neonatal units. And then what I'll have to do is we'll have to talk to the neonatologist and make a plan, because unfortunately, as I stated, it also picks up severe prematurity. And so a certain number of these infants are just going to be normal, and we're just going to have to watch them close until we're certain of that. So it won't be, for like nursing staff, I don't think it's going to be much different than what you're doing right now. But the first thing that I would say is, you know, when in doubt, call us.
Thank you so much.
Any other questions for Dr. Wilson?
Okay.
Okay. Excellent. Thank you so much, everyone, for joining us. Thank you, Dr. Wilson. This was fantastic.
Thank you. All right. Have a good afternoon, everybody.